I'm delighted that we're able to talk about relapsed refractory myeloma. The one challenge is that myeloma is a genetically driven disease. The second challenge is one of our patients becoming refractory to the main agents that are available for treatment. The third challenge is the fact that we are treating, on average, patients around the age of 70 at diagnosis. And as patients relapse, we typically finding the first remissions do push out the later relapses into about 5 years from the time of diagnosis. The final challenge is about quality of life. And what is very obvious to all of our eyes is as patients move from first line therapy on to third, fourth line, or patients who end up in supportive care, you can see a distinct drop in quality of life over time.
PIs, IMiDs, and monoclonal antibodies form the backbone of the treatment for myeloma. However, most patients become resistant to these agents, and these agents are more and more used in first line of therapy in combination. In this context, selinexor is the first selective nuclear export inhibitors approved for the treatment of relapsed myeloma and has demonstrated efficacy in patients with early relapse after 1 to 3 prior therapies. So you can see on the slide the mechanism of action. XP1 is a nuclear export protein that transports nuclear proteins to the cytoplasm via nucleopore complex. And XP1 is overexpressed in many tumor types, including myeloma. Selinexor blocks XP1 so it cannot carry cargo out of the nucleus. So we have also CAR-T therapies, efficacious and approved in heavily pretreated patients and recently been approved in patients with early relapse, but the combination of selinexor VD can be an option in a very early relapse setting.
We have an increasing number of patients with multiple myeloma that are lenalidomide and or daratumumab refractory at early relapse. So class switch is recommended to improve outcome. We see patients that are mainly lenalidomide refractory, and here the treatment regimens are really limited to POM-VD, KD, selinexor VD, and we have drugs that are non-T-cell based like selinexor or melflufen, and we have T-cell based or T-cell directed therapies like CAR T cells, ID cells, cilta-cel, and bispecific antibodies like teclistamab, talquetamab, and elranatamab. T-cell directed therapies have improved the prognosis for triple-class refractory patients, but there are still challenges to be overcome, and optimization of treatment sequencing with T-cell sparing treatments such as IMiDs and XPO1 inhibitors after early relapse may maximize the potential of T-cell directed therapies.
We recognize the three main classes have really become part and parcel of our upfront therapies with PIs, IMiDs, and monoclonal antibodies. They're highly effective both in the upfront and the early relapse setting, but there are several keys to success. One of them is managing toxicities, both acute and delayed, recognizing in addition that because these drugs are used earlier on and in triplets and quadruplets, we are very now soon engendering an increasing rate of early relapse myeloma patients who are triple class refractory and even pentarefractory, as Dr. Einsele described from the Mammoth study. And it's very important to consider novel mechanisms of action in many of these patients, including the selective inhibitors of nuclear export and the T-cell redirection therapies such as CAR-Ts and bispecifics. When we think about some of the main courses of therapy, we see here a list of some of the more common drugs that we use in myeloma with relative dose considerations for patients who are fit, intermediate, or frail. Along the way, making sure that we optimize and reduce risk of death from infectious issues with appropriate prophylaxis and vaccination, IVIG when appropriate, and making sure we assess cardiac risk and thrombotic risk to prevent cardiac compromise. Really just kind of summing it up, myeloma is a continually evolving field. This is an amazing new world, but we need to recognize that despite these great remissions, people do relapse. And in managing relapse disease, we need to go beyond the classic IMiD PI monoclonal antibody with some of our novel agents like BCMA-targeted drugs, GPRC5D, and XPO1 inhibition. Thank you all for tuning in.